Welcome to our fourth PowerPoint presentation for radiology. For the present topic in pulmonary radiology, we are going to discuss on the mediastinum and the hila. We are going to divide the mediastinum into the thoracic inlet, which is also known as the superior mediastinum, and the inferior mediastinum will compose of the anterior mediastinum, the middle mediastinum, and the posterior mediastinum. So we are going to discuss the different masses that can be found in these areas. For the thoracic inlet masses, this may come from the thyroid gland, the parathyroid gland, or this could be from the lymphatic channels in the neck. So for the thyroid gland, we have goiter, thyroid carcinoma, and thyroiditis. The parathyroid gland may fail to separate from the thymus and descend into the anterior mediastinum. Your lymphangiomas are dilated lymphatic channels. The cystic or the cavernous type, which is also called as the cystic hygroma, is most commonly seen in infants. For patients with thyroid masses, they usually complain of dyspnea or dysphagia because of tracheal or esophageal compression. Coarse or clamped calcifications are common. The trachea is deviated laterally, posteriorly, or anteriorly by the enlarged thyroid gland. Thyroid goiters arising from the lower pole of the thyroid or the isthmus can enter the superior mediastinum. So here is an example of a thyroid mass. On the left side, you can see the enlarged thyroid gland on the left side going into the mediastinum. The arrow is pointing on the trachea, which is deviated to the right side. For you to easily find the abnormality, I have placed the normal chest X-ray on the right side for comparison. You can see in the normal chest X-ray that the trachea is air-filled and is seen in the midline, and there are no masses seen in the neck and the superior mediastinum. The image on the left side is a normal ultrasound of the thyroid gland. You can see the right lobe, the left lobe, the isthmus anteriorly, and the black area posteriorly is the trachea. On the right image, you see a large cystic structure which is hypoechoic. When it's hypoechoic, it's fluid on ultrasound. The gray area on the other image, which is pointed by an arrow and labeled solid, is a solid nodule in the thyroid gland. So on ultrasound of the thyroid gland, here are the different images seen to indicate the risk of malignancy. So for lesions which are hypoechoic or black with irregular borders and with tiny calcifications or microcalcifications, there's a high suspicion for malignancy, and also for lesions with irregular margins. Intermediate suspicion with 10 to 20% chance of malignancy can be given on patients with nodules showing a hypoechoic nodule with regular margin. As we go down the images, there's lesser chance of suspicion, and If the nodule is hyperechoic or isoechoic, then there's low suspicion of malignancy ranging from 5 to 10%. This is also true for lesions which are partially cystic with eccentric solid areas, or and the nodule here in the last picture, which is also a partially cystic nodule with eccentric solid portion. Very low suspicion is given to areas which have spongiform appearance, and also cystic lesions with septations, and less than 1% chance of malignancy is ascribed to nodules which are cystic in nature. Sometimes your solid nature would appear as black or very gray on ultrasound, but one differentiating point for a cystic and solid portion, cystic or solid nodule, is the posterior acoustic enhancement, meaning if it's cystic, you can see very well entirely on the posterior aspect of the mass or the nodule, and you can see bright shadowing enhancement on cystic nodules. So here is a picture of a hyperechoic nodule with abundant color flow on Doppler ultrasound. So vascularity is also assessed when we do ultrasound to check on the function of the nodule. If you see abundant vascular markings, then it's a hyperfunctioning nodule. This being a hyperechoic nodule is we give low suspicion of malignancy in this type of nodules, but showing abundant color flow means that it's a hyperfunctioning nodule. Your color Doppler is also important in differentiating nodules, malignant nodules from benign nodules, because your malignant nodules will show color flow on Doppler study, where your benign nodules will show very minimal, if none at all. So here is your thyroid gland on CT scan. The images on the left will show you a normal thyroid gland with a homogeneous attenuation. So we use the term attenuation for CT scan or density, no? While on ultrasound we use echogenicity. So here on the right images, you can see a hypodense or hypoattenuating nodule on the left side of the thyroid gland. And on the middle picture, you can see a hypoattenuating nodule, which is eccentric on the right side. And on the last image, you can see a fairly defined nodule on the left side of the thyroid gland. So here is another example of your thyroid gland on CT scan. On the image on the left side, the first image is an axial view of the neck, showing markedly enlarged thyroid gland more on the left side. The left thyroid gland shows heterogeneous attenuation. And the image labeled B is a coronal section of the neck, showing the thyroid gland also. The hypoattenuating area in the middle is your trachea. So the pictures on the right side is a chest x-ray and a CT scan of your thyroid gland. So here we see a mass lesion pointed by two arrows on the left side with note of a coarse calcification. And the coarse calcification is marked by a green arrow on the left side. in the last image. So cystic hygromas are dilated lymphatic channels as discussed earlier. And we can see here an an ultrasound of a pregnant woman with the fetus showing cystic areas posteriorly at the cervicothoracic area posteriorly. So that's an example of your cystic hygroma. While the picture on the right side is a chest x-ray showing an area of increased density in the left cervicothoracic area, and that's indicative of that's suspicious for a cystic hygroma in a young patient. You can verify this also by ultrasound, and it will show you tortuous dilated cystic structures. So for the anterior mediastinum, we can see different masses, mostly of thymus origin. So we have thymomas or thymic epithelial neoplasms, thymic cysts, thymolipoma, thymic carcinoid, thymic hyperplasia, thymic lymphoma, germ cell neoplasms, thyroid mass, and mesenchymal tumors. Thymomas are the second most common primary mediastinal masses in adults after lymphoma. It may be encapsulated or non-invasive, or it could be invasive. The average age at diagnosis is 45 years old. It is rarely seen under the age of 20 years old. It is most often associated with myasthenia gravis, but can also be associated with pure red cell aplasia, Graves' disease, Sjogren's syndrome, and hypogammaglobulinemia. It may present as round or oval, smooth or lobulated soft tissue mass arising near the origin of the great vessels at the base of the heart. Your high-grade thymomas tend to be larger, with more irregular borders. It has heterogeneous enhancement, presents with necrosis. There could be mediastinal nodal metastases and calcifications. This is a picture of your thymoma. You see widening of the superior mediastinum in this patient, and on chest x-ray on the left side, and on the right side, you see a mediastinal window of the chest CT scan, and you see a lobulated hypodense mass in the anterior mediastinum. Thymic cysts may be congenital or acquired. Your congenital type are remnants of the thymopharyngeal duct, while the acquired type may be post-inflammatory in nature, and it is associated with AIDS, prior radiation, Sjogren's syndrome, myasthenia gravis, and aplastic anemia. For differential diagnosis, you can consider cystic degeneration of thymoma or lymphoma, germ cell neoplasm, or lymphangioma. Another rare lesion is your thymolipoma. It consists primarily of fat intermixed with rests of normal thymic tissue. They are asymptomatic, thus they are typically large when first detected, and it can envelope the heart and the diaphragm. For cure, the mass has to be resected. Part of the neuroendocrine tumor is your thymic carcinoid. It's a rare malignant neoplasm. 40% of patients have Cushing's syndrome, and it is indistinguishable from thymoma. Hyperplasia can also affect your thymus gland. The difference is that in thymic hyperplasia, it is normal on gross and histologic examination. It occurs in children in response to antecedent stress, discontinuation of chemotherapy, or treatment of hypercorticosolism. It may be associated with Graves' disease. Lymphoma is the most common primary mediastinal neoplasm in adults. It can be Hodgkin's or non-Hodgkin's type. The lymphoblastic lymphoma and diffuse large B-cell lymphoma are the most common type of the non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is multifocal and presents as a lobulated mass. Calcification is uncommon, and splenomegaly may be seen. Imaging studies used for diagnosing or assessing your lymphoma are X-ray, CT scan, MRI, and PET scan. So here is an example of your lymphoma on chest X-ray shown in the image on the left side. You have widening of the superior mediastinum, and you have these lobulated densities on both sides, which are enlarged lymph nodes, as shown on the CT scan on the right side. So you have these nodular opacities in the mediastinum, anterior and posterior to the great vessels. These are enlarged lymph nodes indicative of lymphoma. Differential diagnosis could be metastasis. Your germ cell neoplasms may be due to teratoma, seminoma, choriocarcinoma, endodermal sinus tumor, embryonal cell carcinoma. Among these, the most common is teratoma. It contains tissues of ectodermal, mesodermal, and endodermal origin. Cystic teratomas are benign with female predominance. Solid teratomas are usually malignant and is more commonly seen in males. Benign lesions are round or oval with smooth margins. Ill-defined margin will again suggest malignancy. Calcification is seen in 30 to 50% of cases. So here is an example of your teratoma on CT scan. You have a solid mass with some cystic areas, and you have areas of calcification. For the middle mediastinum, we can have lymph node masses, foregut and mesothelial cysts, which comprises of bronchogenic and pericardial cysts, tracheal and central bronchial neoplasms, diaphragmatic hernias, vascular lesions. And for our last slide, just to enumerate to you the lesions for the posterior mediastinum, we have neurogenic tumors, esophageal lesions, foregut cysts, and vertebral lesions. Please be reminded, as I told you in the earlier lecture, that you only have to know your anatomy, know the contents of the different parts of the mediastinum, and you will be able to know what tumors can be found in those locations. We have discussed some of these lesions in the first lecture, and just go back to it and review it. I've shown you an esophageal lesion. I've shown you a neurogenic tumor. So just review those slides so you will be updated. I leave to you to read on pulmonary infections, diffuse lung diseases, airway diseases, and the pleura, the chest wall, and the diaphragm. I've also presented to you examples of these diseases in the first study. Please read your books. Our recommended book is The Fundamentals of Diagnostic Radiology by Brandt and Helms, 4th edition. So please read your books during your free time, so you can be further enlightened with radiology. I hope I'm making radiology interesting, and I hope you will be interested to join us later when you graduate. So thank you so much for your time. Thank you so much for listening, and we'll see you on Friday for our discussion. Thank you.